this idea of moving away from fee-for-service towards more quality measures, more value measures. I think we've had some progress on aligning incentives, but the fundamental question that is in front of all of us is, are we doing it right? And the next 5 to 10 minutes, I want to talk about that and try to answer the question, are we thinking about value right? So one way to think about that is to look at Medicare's payments for hospitals. So policymakers would say, look, we are now tying 6% of all Medicare payments to value. That's a big number. If you think about the average hospital in America, the average margin, 1%, 2%, 3%. So if 6% of your Medicare payments are tied to value, that's enough to get people's attention. But the question is, how are we defining value? So this is how CMS is defining value. Readmissions, hospital-acquired conditions, these are sort of billing code-driven measures of patient safety. And then this, right? So mortality in patients, for instance, we're saying readmissions counts for about 5 times as much as mortality. I agree readmissions are not great. The question is, are they a fate 5 times worse than death? It's not totally clear. But the point is, these are the measures by which we are defining value in hospital care. And these are the weights that we are providing on them. Weights are really important because you can have 10 measures, but if one really drives the ship, you have to understand that's where everybody's going to focus. So if that's our approach, which is now the national approach, so again, we all can say, well, that's not how I would do it, and I would say that's interesting, that's how Medicare's doing it. And because that's how Medicare's doing it, that's how private payers are doing it. So I thought it would be fun just to look at which are the 3 hospitals in Massachusetts that are the best, according to the new value formula, and which are the 3 hospitals in Massachusetts that are the worst, based on the new value formula. So I'm going to show you the 3 best states in the Commonwealth of Massachusetts based on the value formula. And these are the 3 best. Okay? They're the best ones. Most hospitals end up getting penalized. They actually get bonuses because they do so well on these measures. These are the 3 worst. Tufts Medical Center, the worst hospital, and Boston Medical Center. So you look at this and you think, is this just about quality and value? Or do we think something else might be going on? You get a sense that maybe the underlying patient populations are a little different. Maybe the complexity of the cases that they're managing might be a little different. I don't know. That's just me speculating. Your views on it may differ. But I think it's important to understand when we move to a value-based world, there are going to be winners and losers based on how you define value. In our first pass at defining value for hospitals, those are the winners, those are the losers. So it raises the question, is this really value? So let's talk a little bit about how we might get to better value. So the first thing in my mind is we have to begin to measure what matters. So our measurement strategy has been primarily focused on measuring what we can measure. Why are we measuring readmissions? Because it's really easy to measure. Right? You have claims data, you can look at when somebody was discharged, you can figure out when they were readmitted. It's really straightforward. And our strategy on measuring value, measuring quality, has been primarily driven by measuring what we can measure. And that may be an okay place to start, but that is not an okay place to end up. And so the question is, how do we begin to measure what matters? So what matters? This is my list. Your list can differ, right? This is why we have to remember that value is about values, and everybody's values are a little different. I think there's a lot of stuff that's going on safety that we don't measure. Right? Diagnostic errors, really important issue, no measures, because they're really hard to measure. Patient-reported outcomes, functional status, patient health and well-being, right? And then the other part is think about focusing on change. And this is what I mean by this, is as a clinician, if you think about your job being about improving the health of people's lives, the lives of people, improving people's health. The job of a physician, and I'm going to pick on Newton Wellesley because it's a mile from my house. We've used it. It's actually, I think, a fantastic hospital. But the job of the average physician in Newton Wellesley is different than the job of the average physician at Boston Medical Center. It just is, right? And our job is to take patients as we find them and figure out how to help them get better. It's about change. right? You can be a lousy provider in a community where everybody's healthy and you'll look much better than being a terrific provider in a community where everybody is sick. And so I think we really have to look at is about changes in health status, changes in functional status, changes in outcomes, and not just absolute levels. Because if you look at absolute levels, you're going to get Newton-Wellesley will beat Boston Medical Center every day of the week, no matter what you do. But that's just, again, it's my take. We have to sort of think about change. Yesterday, I made some changes to this slide, actually, last night and this morning, because I had lunch yesterday with a colleague of mine who's a geriatrician who spent most of her career focused on the frail elderly. And we were talking about values, and I was telling her that I was talking today. And she reminded me that if you take somebody who's old, who's frail, and ask them what do they value the most, she rattled off a list. I wrote it down, and this is the list that she rattled off. I think it's a pretty good list. She said, you know, what do older, frail people care about? And again, not all of them. Everybody's a little different. But people care about things like maximizing physical comfort, avoiding delirium, receiving treatment at home, meaningful interactions with family and friends, maintaining maximum possible independence, reducing burden on family and caregivers. It's a pretty good list of things that some people who are frail and older and struggling might say, this is my set of values. And they may not come up with the same list that Medicare comes up with. But we don't measure any of this stuff, right? And we certainly don't figure out, are we able to achieve this? You know where we do measure this stuff, and the way we do it is the way we practice medicine. We actually know this when we take care of patients, that that's what they care about. But it doesn't show up in any value payments. It doesn't show up in any value measurement. So the question is, are we measuring what matters? I would argue that our current approach has some strengths. It focuses on evidence-based standards. It has some degree of focus on outcomes. It has two sets of shortcomings. One is technical. We don't do a very good job. I think a lot of our measures are deeply flawed. They don't do a good job of dealing with risk adjustment. They don't do a good job of managing socioeconomic status. But in many ways, they're more social and humanistic, because I do believe value is about values. And the notion that priorities of what is high-value healthcare can be determined in the District of Columbia or on Beacon Hill and create a one-size-fits-all of what is high-value healthcare is going to be very difficult, and it often will fail to measure what matters. So what do we do? A couple of things. I think one is we need a broader, more robust measurement effort. And I'm going to put up the next point on this that's going to make some of you cringe, but then I'll explain why I'm saying it. So use the EHR. Now, electronic health record adoption, I've studied this very closely. This should create a certain amount of pain in all of us. The transition has been painful, it has not gone as smoothly. The biggest reason I put this up is because the whole value of electronic health records is supposed to be that you don't have to click on buttons to do. I mean, I'm not saying that this is how we're doing it, folks. I'm saying that the idea is once you really capture the clinical encounter in the electronic record, you should be able to pull out things like what matters to patients, how well we're achieving it from the data that's in there. Again, I'm not arguing that that's what we're able to achieve. I'm saying that's the holy grail. That's what I want to push us towards. I think that's where we should be going. I think we need more patient-elicited measures. I think we need to, again, I've talked about measuring what matters. Paying for quality, this idea that we're not going to pay for quality, we're going to have a pure fee-for-service world where you just get paid for service, that's done. I mean, I told you there's both broad consensus. Nobody's going away from paying for quality. I think we're going to have to pay for quality. But I think we need to let patients and providers drive much more the value agenda. I have some thoughts on that, and I'll let you guys, I'll get back to that in a moment. I'm about to finish. I want to finish with this quote. This is from a colleague of mine who is an advisor to the Obama administration, and I think this line perfectly captures the thinking. What I thought was really interesting about this line, healthcare payers have concluded that medicine is too important to be left to physicians alone. It wasn't the healthcare system is too important. It is medicine is too important. So that was an if he had said have concluded that healthcare system is too important, I would have been more open to this notion. But it is that medicine is too important to be left to physicians alone. Well, I'm with you, but this is what we got. And I think the question is, how do we begin to change this conversation?
That's the the reason that you have that curve of the administrators.
Correct. Correct. They would say, we have met the enemy, and the enemy is us. That is the feeling. So what can we do? Well, this is supposed to show up in points, but I think, well, let me just I'll make some of these points so you can just focus. I spend a lot of time in Washington, D.C., and a lot of policy discussions. One of the things that I find is that I'm often one of the very few physicians in the room, and I'm almost always the only practicing physician in the room. And so while I was invited not because I'm a physician or a practicing physician, I find that the value I add to those conversations is in that role. I'm there as a professor with data and blah, blah, blah. But what I am doing is trying to talk about what this stuff will mean when you're in an exam room, when you're in the emergency room, when I'm in a hospital room. I'm a hospitalist, and I talk a lot about what it means, what these policies and what these things, how they actually affect what happens when I'm with the patient's family, in a hospital room, somebody who's very sick. We've all had a version of that experience. That is something that is a conversation and a perspective that is missing from most discussions, which is why I think you end up with a lot of where we end up.